Thank you very much, Rini, and thanks to PK for this invitation. Really appreciate that. I have 10 minutes to go over the entire Tibial algorithm. So we'll read, these are my disclosures. So before I start, I wouldn't say this is my algorithm. A lot of people are involved in coming up with this strategy. So there was this paper, actually, Sahil and Brian were part of that as well. Banerjee came up with, and Art and us, we all sat together and we came up with a strategy for CTO crossing algorithms, logic flow charts and stuff. And it was very interesting. They selected 10 to 12 centers with busy centers that have a lot of CTO cases and came up with case submissions and the techniques, the wires, the catheters, the devices to come up with this paper that was published in published in actually JIC. And it's actually good. It talks about clinical considerations, anatomical considerations, and relative contraindications. And what this paper does is more so above the knee, but also BTK, below the knee interventions, talk about algorithms of what to do and what not to do. And what it does is it specifies on few things other than the devices, is also access and the techniques. It also talks about the CTOP classification, talks about the crossing maneuvers to be done, wire utilization and stuff. And without going into detail, what it does is systematically just goes through to help out people who are starting to do this, that what should be the techniques they should utilize. For example, if you talk about BTK CTO, if you're using the guide wire, is it polymer jacketed one versus non-polymer, and what could be the effects of that, where you utilize that with a crossing device versus retrograde or pedal looping coming from below or coming from above. And then you give examples of cases where we actually talk about different techniques in relation to the algorithms that were utilized for this paper. And differentiation of different guide wire techniques, because just to say when you escalate or de-escalate, or when you go from the 014 to 018 or 035 or go the other way around, what are the wires that are commonly used and what we do usually, and also the devices. But the whole thing sets on this work that I was very lucky to be part of it with Dr. Mustafa and Saab, and they took us to these secret locations where we wanted to study with Renu Vermani. She's a well-known pathologist, amazing lady, about the atherosclerosis pattern in tibials. And this is the work that they did, which actually showed us that the tibial arteries have different calcification patterns. There's proximal atherosclerosis. If you notice the thickness of the vessel wall, which complete amount of loss of vessel lumen over there. And if you look at the pattern of these calcification, it's near circumferential. It's both in the intima and media, and you could literally see microcalcification, the black dots. You see literally osteoblast bone formation and bone marrow formation in the vessel wall. And these are the pictures of the intimal calcification that shows the same thing. The black dots will show you the osteoblast. So there are 3 layers of calcification over there. And all these 3 layers, in order to get from one to the other, you have to crack the first shelf in order to get to the third shelf. That's why absorption has been an issue. The plaque types are completely different in above the knee versus below the knee. If you look at the microcalcification, is minimal in the ATK, but highest in the BTK, but the plaque formation is the other way around. So the pattern of tibial vessels, tibial arteries, and their calcification is completely different. This just clearly shows the pattern of the 3 layers of calcification that we need to crack in order to get to the lamina. And that's the big problem with absorption. It's literally bone formation within the vessel. Calcified artery with true bone marrow formation within the arterial wall. So this was all based, this was a histopathological surveys, and then coming back to the imaging things, that was the PRIME registry came up with the CTOP classification that we all know and talked about. So without going into much detail in that, there were like almost 900 cases that were selected from this registry to study this, from the PRIME registry, over 3 years. And these were long lesions, not like others that we have in other trials. But the big complaint is most of the trials do not have these long lesions. And 114 patients initially went up to like 900 cases in total. And this was the algorithm that they came up with to define a CTO length first, then axis selection, extremely important, antegrade versus retrograde versus dual. And we saw that 95% of cases in the registry that had initial failure on the second retrograde attempt due to the axis issue. So axis is very important in the algorithm for crossing these. And then also depends on revascularization strategy, because the question is, does atherectomy help or not? And we'll talk about it. So we know about the CTOP classification. I'm not going to go into detail of that, but it really depends on our imaging modalities, ultrasound, IVUS, versus angiography to see what kind of concavity or convexity we're coming in to go through. The same applies above the knee versus below the knee. And what it helps is this CTOP classification within the primary registry showed us the success rates of adopting that and the failure rates of not adopting that. So that was the main thing that we came across on there. And access, once again, converting your access or utilizing the correct access showed the significant success rate in doing these cases. The calcification and the long lesions of all these things are recorded because these were really extreme complex cases that I would say. And what it does, it actually helps you to also utilize the techniques that are available. So depending on the CTOP classification, if you want to come from above or below, or use crossing devices, or utilize strategies of extralumen or intralumen conversion and needle techniques. So the advanced techniques really help, but you go through that depending, again, like I said, if you struggle with the two concavities on the other side. And then what it helps is if you come integrate, so you have big pushability in these cases. And that really helps to, for example, for the type 1, antegrade would be a better approach compared to type 4, which would be a retrograde better approach. And for 2 and 3 lesion length greater than 10, severe calcification, a dual access strategy and a pedal strategy would really help. So an example, let's see if it works. This is the case where we talked about the technical evaluation before. And let's see if we can come from above. Initially came antegrade from above. We see if we can cross. We were unable to cross, utilize all the techniques, crossing devices. We were able to make some advancements, but not completely. We got stuck because there was calcification over there. Utilize ultrasound, and we see that's the ultrasound, that's the calcification spot that is hitting and giving trouble. And that's why I decided to let's have the dual access come from pedal from below, because we know we were subintimal from above. We made the entry from the pedal access utilizing the V18 wire, went in, tunneled, and within the access to tunneling, 3 minutes and 45 seconds versus what we were trying to do from above. So it really helps you to shorten the case duration, applying these algorithms, and also utilizing less contrast, less radiation for the patients as well. So it was a remarkable achievement on that behalf. And the other question also come is what about those non-dilatable, heavily calcified tibial vessels? So this is another case of a 67-year-old male who comes in and in the office decided to plan out to do this case. We see the very calcified popliteal going into the AT and the PT from right above there. We don't see where it starts or where it ends. The tibial vessels, and where is our wire? We don't know if it's subintimal versus where it stands, but we came across, okay, it's type 4 CTO, so the solution is we're going to have our dual access strategy, taking advantage of the pedal access coming from below. This is the tunneling technique. So literally these techniques utilizing the classification of not only the crossing and the CTOP classification, but also our dual access strategy, taking in viewpoint, understanding the different anatomy of the vessel and understanding the morphology of the disease, helps us to do the crossing, utilize this strategy. Now, what would we do if these vessels that we crossed and we're not able to deliver therapy? So that's the other thing, to come across revascularization strategies utilizing perfect vessel prep, because if we don't plan out, we are planning to fail. So vessel prep with full expansion, utilizing the devices that we have, scoring balloons, atherectomy, that's a big question, because one thing is, okay, if we spasm and if we're not opening and we're mixing that with other strategies. So we came up with another strategy we call the TEC mix. Dr. Mustafa wanted to call it the ACV mix, but I said the Texas TEC mix I'm going to call, where a different combination of verapamil, adenosine, nitrite, and nitro we mix. And we come up with this thing which really helps out. And we have studied this in multiple things. Just for the sake of time, I'll go quick on that. So in short, calcified intrapopliteal disease is more common. Debulking artery calcium is necessary. Many devices are available, and they all have their place. And there's comparative data to show different strategies on them. It is a completely different pattern of calcium in these vessels, and it's a different vessel wall anatomy. These are the devices that can be used, and there's different data. But in the end, I'm going to end with one study that we did, and this is the atherectomy study that we did at Texas Tech in collaboration with Dr. Mustafa as well. We compared it with the meta-analysis which is out there, and we had a total of 9,874 patients in this. And this is the chart that I want to share. If you look at it was not showed statistically significant on its say on this meta-analysis and review, but what it clearly shows is the TLR and amputation, like Beyonce says, to the left, right? So it clearly shows the trend that benefits. So if anybody asks a question, does it work or not work? There are a lot of things we do with our experience when we look at the trends. And if I have a trend showing me better rates of less amputations, I'm willing to take it. Once again, amputation is a disease of the entire family, so anything we can do to help it. So my ending note is going to be our outcomes depend on calcification, which needs proper revascularization, including atherectomy, that should be included in our algorithm, safe and effective management, and each device has a specific use and specific morphology that should be utilized. So in 10 minutes, I finished my algorithm. Thank you.